On behalf of the Rsna, thank you for joining us for today's webinar, The Role of Imaging in the Diagnosis and Treatment of Multiple Sclerosis. Rsna also thanks cortechs.ai for sponsoring today's webinar. My name is Alex Rovira. I am a full-time neuroradiologist, gaining my medical degree in 1983 at the University of Barcelona. I serve as director of the section of neuroradiology at University Hospital Vall d'Hebron in Barcelona, Spain, as professor of radiology and neuroimmunology at the University of Barcelona, and honorary associate professor at the University College of London. My main area of clinical and research interest is multiple sclerosis and related disorders. With us today, we have Professor Maria Rocca, Dr. Suzie Bash, and Dr. Lauren Stannenbaum. And before introducing the speakers, there are a few things to let you know. This webinar is one of the many ways Rsna is reaching the radiology community to provide education and resources. Today's webinar will be recorded and available for free in the Rsna Online Learning Center, as well as Rsna's YouTube channel. Here is the disclaimer of Rsna. Please use the question panel to submit your questions during the webinar. And now I would like to introduce the speakers. The first one is Dr. Maria Rocca. She's head of neuroimaging of CNS White Matter Unit at San Rafael Scientific Institute and associate professor at Vita Salute San Raffaele University in Milan, Italy. Her research activity has been focused on the use of structural and functional MRI to improve our understanding of CNS function in healthy subjects and the progressive accumulation of irreversible disability in neurological disorders, mainly MS, but also vasculitis and migraine. She has authored over 520 papers and is member of the editorial board and reviewer on a regular basis for several international journals. The next speaker, the second speaker, is Dr. Suzie Bash. She is the medical director of neuroradiology at San Fernando Valley Interventional Radiology at RadNet. Prior to this, she was on the neuroradiology faculty at UCLA after completing a 2-year neuroradiology fellowship and residency also at UCLA. Dr. Bash's passion and interest lie in artificial intelligence applications in advanced neuroimaging. She is a recurring guest on TV and podcast and is actively involved in artificial intelligence clinical trials, publications, and webinars. Dr. Bash serves on the medical advisory board of several artificial intelligence companies and the editorial board for Applied Radiology. And finally, the third speaker is Dr. Lauren Stannenbaum. He is Vice President and Chief Technology Officer at RadNet. Previously, he served as an Associate Professor of Radiology, Director of MRI, CT, and Outpatient Advanced Imaging Development at Icahn School of Medicine at Mount Sinai in New York. Dr. Tanenbaum is interested in developing applications of contrast agents, MR, CT, and advanced rendering in the clinical practice of medicine, focusing on efficiency, radiation dose appropriateness, and physiologic imaging. Before the presentations of the guest speakers, I would like to start things off by getting to know our audience a little better. And we will do that by asking these 4 questions. And we would like to know the answers of your questions, of these questions from all of you. Can we have the questions? Well, the questions are, do you routinely use a tool for automated segmentation? The second one is, do you routinely use a tool for automated volumetrics? The third one is, do you routinely use a tool for the volumetric assessment of lesions in MS patients? And the last ones, are you or your colleagues exploring artificial intelligence-based applications for your practice? Please answer the questions, and we will see the results at the end. Okay. So let me introduce the first speaker, Dr. Maria Rocca, that she will address the clinical needs and relevant questions like what do we need for diagnosis and what measures should we use and when in our clinical or even in the research scenario. Please, Maria.
Thank you, Alex, for the introduction, and thank you for the invitation to this webinar. So my task today is to discuss with you, as Alex was introducing, the clinical questions when we want to use some automated methods for the quantification of lesions and atrophy in patients with multiple sclerosis. And I decided to discuss with you two different aspects of the disease. The first is related to the diagnosis of multiple sclerosis, and the second one is related to monitoring disease in terms of worsening of disease course or addressing possible treatment effects in terms of response to treatment. We know that for the diagnosis of multiple sclerosis, we need to demonstrate disease dissemination in space and disease dissemination in time. The third main requirement for making a proper diagnosis of multiple sclerosis is to rule out other possible conditions that for their clinical or laboratory pattern of manifestation can mimic this condition. MRI has been formally included into the diagnostic workup of patients with multiple sclerosis in 2001 with the McDonald diagnostic criteria. And the inclusion of MRI into this diagnostic process was due to the fact that there are some features on MRI which can be considered as typical for multiple sclerosis in terms of location of lesions, distribution of lesions, and evolution of lesions over time. From their initial introduction into the clinical practice, these diagnostic criteria have been revised and modified several times over the course of the years. And I just want to remind you two major changes that have been done to these criteria. The first one occurred in 2005 when the assessment of spinal cord lesions was included to demonstrate disease dissemination in space, while the second important change was done with the 2017 revision of the criteria when the assessment of cortical lesions was informally included. So at present, to demonstrate disease dissemination in space, what we need to have is at least 1 T2 lesion in 2 of the 4 CNS areas that are usually affected by the disease, while for demonstrating disease dissemination in time, just focusing on imaging, we need to have some measures of active inflammation, so or new T2 lesions or the presence of gadolinium-enhancing lesion. As I was mentioning before, one of the main changes to the current diagnostic criteria has been the inclusion of cortical lesion assessment. And the assessment of cortical lesions is important because, as it has been demonstrated by several studies, it seems to increase the specificity of these diagnostic criteria, so reducing the risk of misdiagnosis. The main issue we need to consider when assessing cortical lesions is that at present we do not have a standardized sequence for a proper recognition of these lesions, even if different sequences have been proposed, including double inversion recovery sequences, PSIR sequences, or the old FLIR sequences. Another question that we might have for concerning the diagnosis is whether we might think to develop some algorithm based on artificial intelligence, which might help to have a automatic classification of patients as belonging to a given neurological condition. This is what we did, for instance, in this study that you can see here, where we developed a convolutional neural network algorithm, and we compared the performance of this algorithm with the performance of 2 expert neuroradiologists in the classification of 4 different neurological conditions which are characterized by the presence of lesions within the 1 meter. As you can see from the number, the automatic algorithm outperformed the 2 expert neuroradiologists for all these different conditions. However, there were different cases of misclassification also from the automated algorithm. And this is important since we are dealing with patients at the beginning of a disease where we need to make a diagnosis, and we also need to make some decision concerning a possible treatment. So for diagnosis, it's clear that the simple evaluation of lesion burden, lesion number, lesion volume is not sufficient. We need to integrate what is observed from MRI with the clinical and paraclinical data. Another question might be whether we might be able to identify some distinctive MR features which could be considered as pathognomonic of a given condition. So for clinicians, it's extremely important to have some practical guidelines to be able to properly identify lesions that are characteristic of a given condition, and also to have guidelines for a proper application of the criteria for the classification of patients and for the definition of disease dissemination in space and time. Concerning the possibility to identify some pathognomonic features derived from MRI, the most appealing feature at this stage is represented by the assessment of the central vein sign, which seems to categorize quite well patients with, to separate quite well patients affected by multiple sclerosis from patients suffering from other inflammatory mediated neurological conditions. The second aspect I would like to discuss with you is whether we can use different methods based on the quantification of MRI measures to try to have an assessment of the burden of the disease and also of the effects of treatment. And considering the burden of the disease, the measures that are currently proposed to have a sort of overall estimate of the disease-related processes that have occurred over the course of the disease are represented by the quantification of T2 lesion volume and by the quantification of brain atrophy, which actually reflect the balance between different pathological processes, and in a simple way, they simply reflect the balance between the accumulation of inflammation and also the progressive accumulation of irreversible tissue damage and neurodegeneration. Moving to treatment monitoring, the 2 aspects that are usually considered important when we start and when we want to assess the effect of a given treatment is the evaluation of the effect of this treatment on in terms of anti-inflammatory activity, and this is done usually by quantifying new T2 lesions and gadolinium-enhancing lesions, and also in slowing down the progressive accumulation of irreversible tissue loss, so slowing down the progression of atrophy. Considering the increasing number of treatments that we have and the fact that the majority of our patients is currently under treatment, another important point that we need to consider when addressing an MRI and treatment is that we need to be able to recognize in an early stage possible treatment-related side effects. And I'm considering here not only the issue of PML, which is well known to all the radiologists, but also other issues that have been described with some of the newest treatment, which are mainly related to the possibility to develop different forms of infection. Considering disease burden, usually the assessment of a T2 lesion volume is done by using a manual assessment. This is usually considered as the gold standard for such an assessment. This is extremely time consuming, particularly when we have patients with a high lesion load and suffer for a low intra and interrater reproducibility. This is why, as you will hear from the next speakers, there has been the current attempt to try to develop different automated methods for a proper identification and an automated identification of lesions, which can be done by using a single MR modality or by integrating different MR modalities, covering the plane in different directions. And this is done not only for the assessment of lesions within the brain, but also for the assessment of lesions within the spinal cord. It's clear that if we want to have an overall estimate of the accumulation of the disease in our patients and of the effects of a possible treatment on this disease, we need to combine these measures of inflammation and measures of neurodegeneration. And while the assessment of inflammation can be considered as relatively easy, since it's quite easy to identify new T2 lesions or gadolinium-enhancing lesions, I think that the assessment of neurodegeneration and the quantification of brain atrophy could be considered as more demanding. And if we think to include a brain atrophy quantification for the monitoring of our patients, there are many different issues that we need to consider. There are different technical, physiological, biological, and disease-related factors which can actually influence the quantification of atrophy. And if we wanted to use a measure of atrophy to judge whether a patient is doing well or not, and whether a patient is responding or not responding to a given treatment, the main question might be what is the clinical relevant cutoff to judge this atrophy. So to conclude, what I would like to say is that if we think to these automated methods, we shouldn't think to these automated methods as a replacement to the work done by the clinicians, but possibly as an integration to the work done by the clinician in order to facilitate the work of these radiologists and neurologists. Thank you for your attention.
Well, thank you very much, Dr. Rocca. Thank you, Mara, for this nice presentation. And now we will start with the second speaker, Dr. Suzie Bash, who will now review the clinical experience related to the use of quantitative MRI, including how these tools impact the efficiency and how to incorporate them into clinical practice. Suzie, please.
Thank you, Dr. Rovira. So yes, multiple sclerosis is a debilitating and often progressive disease that affects younger adults, so typically diagnosed between the ages of 20 to 49. And, you know, the difficulty is that these patients often present with a highly variable clinical presentation. So they really can present with a broad range of symptoms. And so this is why MRI plays a very key role in the diagnosis and in the longitudinal follow-up of multiple sclerosis. In fact, such an important role as Dr. Rocca was saying, it's even included in the McDonald criteria. Now, with MRI, it often has a very characteristic appearance. So, you know, Dawson's fingers, callosal, pericallosal lesions along the optic radiation and in the brainstem. As you see here in the lower right, we can get that central vein sign. So MRI is we can often nail this diagnosis with MRI. Sometimes if there's only a couple lesions, it's ambiguous, but often to neuroradiologists, this is our bread and butter. And as soon as we open the scan, we can often detect multiple sclerosis. So the thing that I think will be very, very useful and that I find very useful in my clinical practice is quantitative volumetric imaging as an adjunct to the MRI. And so that's what I'm going to spend some time talking about. Now, if there does remain clinical ambiguity, CSF analysis for oligoclonal bands can also be obtained. So quantitative volumetric imaging identifies and labels anatomic structures in the brain, and then it quantifies those volumes of the brain structures and compares that to a large normative age and gender matched database. And then that allows for volumetric tracking over time to assess for a rate of change. And this is very effective in reducing subjectivity. As Dr. Rocca mentioned, once you start to get a moderate or severe plaque burden, the plaques can become confluent, and it's very hard to tell if there's progression. And when it comes to disease modifying therapies, that is really the most important component. Is the patient progressing, and what can we do? Do we need to change the drug? So this is why this tool is extremely valuable. I've actually been using quantitative volumetric imaging in my clinical practice for about 15 years now. This is what the segmentation looks like for this particular product. There are other products out there that, similar sort of segmentation arrangements, but so we use quantitative volumetric imaging for a lot of different clinical diagnoses. This is actually sort of a short list. There's a lot of products in development and other things that are used, but mainly multiple sclerosis, dementia, epilepsy, pediatrics, and traumatic brain injury. And then again, today we'll focus on multiple sclerosis. So the great thing is that quantitative volumetric imaging can identify and quantitate the individual plaques in the brain. So it can do individual lesion segmentation, as you see here, and it also can allow us to see regional segmentation. So this purple is showing us the periventricular plaque, so it can tell us the different locations. So in this example here, the red is leukocortical. These are the juxtacortical plaques. Periventricular is purple, infratentorial is orange, and deep white matter plaques are yellow. This happens to be the NeuroQuant package here. It also very importantly allows us to see dynamic lesion segmentation. So this is another visual display where the plaques that are increased in size or new are displayed as an orange, and decrease is displayed as a blue. And that's very helpful. Again, when you have hundreds of plaques, to allow the software to jump out in a color-coded manner to let you know which ones are new and which ones are improving, I find extremely useful. So this is what you would see on your PAC station, something like this, where these new or increasing plaques are this orangish color and the decreasing plaques are this blue color. And you see how easily that stands out. There are different reports that are used, and I like to go in just to familiarize people with what some of these quantitative volumetric reports look like. This one happens to be the NeuroQuant MS report. Initially, it shows you, again, what the color code is for the different regions of the brain: periventricular, juxtacortical, deep white matter, and infratentorial. It gives you a lesion summary. So it gives both the lesion count. So we have this patient has 96 plaques, and then it breaks it down in the locations. But even more importantly than the lesion count is the lesion burden by volume. So, again, as two plaques become confluent, that may alter your lesion count, but the lesion burden is a very useful number. So this patient has 10.22 milliliters of plaque overall. It breaks it down according to location. We get the lesion burden as a percentage of the white matter and also the volume of T1 hypointense plaques. And then very importantly, we have lesion dynamics. So we get a count of which lesions are new, enlarging, shrinking, stable, and the T1 hypointense. And then it tells you, for example, this enlarging lesion, it tells you what the volume of that lesion is. And it even tells us that this particular one is juxtacortical in location. So that's all extremely useful. We also get other key pertinent structures. So whole brain volume, cortical gray matter, cerebral white matter, and other pertinent structures like thalamus. And so it gives us the current volume, the prior volume, if this is a longitudinal study, and then the volume change over time, and also percentage of the intracranial volume, and then the normative percentile change. So one of the most important aspects, I think, of these quantitative volumetric reports is sort of this lesion dynamic summary that gives us a quick overview of what's happening on the report. So we see here that it tells us the scan date, it contained this many lesions with this amount of burden and involving this percentage of the white matter, and it's 1.45 milliliters more than what it was on the prior scan, and then it gives us the specifics of what has actually changed. Now, this pre-populated sort of summary report, you can actually bring this automatically into your PowerScribe or whatever your dictation system is. So you can pre-populate that in there, or you can cut and paste, or you don't have to use it at all. But it's a very useful tool if you want to use it, and it is included in the reports. We're also given a breakdown. So for example, for a juxtacortical lesion, it's telling us what lobe of the brain that it's involved, and also infratentorial, whether we're in the brainstem or the cerebellum. These bar graphs give a visual analysis of this, and again, telling us what's enlarging, shrinking, stable, etc. We're also told the lesion burden by hemisphere. So this patient has more lesions in the left hemisphere than they do in the right, and that's displayed here by the higher volume here in the left hemisphere. And then we're also given the longitudinal, a visual depiction of the longitudinal element. So the gray dot represents the prior study and the current dot is black. So we know here that the lesion burden is increasing, and we even see, you know, the age of the patient at the time of the different studies. This is just a snapshot that the report provides of some key lesions within the brain, and it shows the, you know, locations. And then we're given normative reference charts, which is just a visual display of what I showed you earlier. So anything in the red is going to be greater than 2 standard deviations outside of the mean. So the cerebral white matter volume is what we call statistically significant, more than 2 standard deviations below the mean. And then we see the trail plot from the prior study. And then I think it's nice in the appendix here, we're actually given the current study and the prior study and the field strength that was done on. I mean, quantitative volumetric imaging really, we want to have the same parameters used on the prior study as on the current study. And we really would like a 3D flare input. If the scanner absolutely does not have 3D capability, 2D can be used, thin slice 2D, but 3D is always preferable. But it's nice to see that we're comparing apples to apples here, so I know what the prior study was. Lesion detection thresholds can actually be set by the end user, which is extremely helpful. I like to use a very small minimum size because the plaques can start small. I also like to use a minimal separation. So I like 1 millimeter because, again, the plaques can be very close together. And for the count, we don't want them to appear confluent. And you can change these thresholds in the different areas of the brain if you would like. So that was one report. This is another report. This happens to be the ICO Brain MS report, and we can take a look at this here. This also gives the lesion volume here, the volume change over time, new, enlarging, and shrinking. Then we have bar graphs here that depict the time point 1, time point 2, and change over time. The second page of the report tells us the whole brain volume, gray matter volume, and then what the normal range is, what the normative percentile is. So this patient's at 3% for their particular age and gender. And then annualized volume change. This is how much volume they've lost since their prior time point. And then the normal annualized is how much that they would be expected to be lost, for allowing for that time for their age and gender. This report also has a pre-populated reporting template that is, again, a summary report that can be pre-populated into your own dictation if you would like. So one of the questions I often get asked is, do these quantitative volumetric tools enhance productivity? And we're all extremely busy as radiologists, and most radiologists operate on an RVU system, and we want to provide the best value. These reports clearly provide value. But the question is are they going to slow us up? Because they will be much less tolerated if they're going to slow us up. So this actually has been looked into. This is just a small clinical trial where a neuroradiologist looked at 100 MRIs. Half of them had quantitative volumetric post-processing and the other half did not. And again, that included the pre-populated reporting template. And it timed and presented in a randomized manner from 11 different imaging sites. And it turned out that the neuroradiologist could read eight MRIs on MS patients without the quantitative volumetric software and 13 with it. So 60% more reports were dictated an hour when quantitative volumetric post-processing was used. So that's very encouraging. And we like to also, at RadNet where I work, we also like to drop on our prescription pads a click box for quantitative volumetric imaging, and then they can just check which protocol they want to use. So obviously the reports are going to look different for the different clinical indications, so they would just click MS. And this makes it nice and easy for our referrers to see that we offer this technology and for them to use. So as Dr. Rocca mentioned, you know, there are specific things that we like to use for the protocol. In October 2019, the Mri Consensus Guidelines Conference was held, and that's really a collaboration of multiple stakeholders in MS patient care and in neuroimaging. A lot of different groups were represented there, and the goal was really to develop internationally accepted recommendations to standardize the MRI protocol for MS. And the most important new thing that came out of the meeting is, again, this emphasis on the 3D flare. So they really only recommend 2D, thin slice 2D if you don't have 3D capability. And then we want those displayed in both the sagittal and axial plane. And the other advantage, not only being much more sensitive if you have a 3D flare, but it also can save time, because if you only have 2D, you're going to need to do 2 acquisitions in the sagittal plane and axial plane. But for 3D, you can just acquire, for example, in the sagittal plane and reformat in the axial plane. So that will save time. They would like a T2 and a DWI, which are routine sequences that we use anyway. And then if you're considering quantitative volumetric MRI, which I would strongly always consider, to acquire a 3D T1. And this, you can do this on any 1.5 or 3T magnet essentially. So this is an easy thing to acquire. The GRE or SWAN is optional for MS, but really, you know, GRE is part of the routine standard brain imaging protocol in most places anyway, and also can be useful for the central vein sign. You can see the central vein sign on FLAIR or T2 or GRE, but the GRE can be useful for that. And then the other big emphasis is on gadolinium. So gadolinium is always encouraged for the baseline MRI. But then after that, you know, these patients come back every 6 to 12 months or so for follow-up studies. So after that, you know, really only if clinically indicated. So if the patient has highly active disease or unexpected clinical worsening or some kind of diagnostic uncertainty, or there's going to be a change in the disease modifying therapy or things like that you really want to use the contrast for, you absolutely can, but you don't need to use contrast for longitudinal follow-up. So that's another important thing that came out of that meeting. Another thing I've been asked before is it possible to effectively apply more than one AI solution to obtain the benefits of both tools, you know, while still maintaining image quality and accuracy? So routine brain MRI often takes 30 to 40 minutes, and that's including table, on the table, scan time, and off the table. But we really would like to get our exam slots down lower. So at RadNet, we actually use 15-minute exam slots for brain studies. And we can use certain AI tools to allow us to do this. So this is deep learning reconstruction, and it allows us, in this particular case, to acquire images 67% faster. This particular deep learning product happens to be Subtle MR, which is vendor neutral, can be applied to any scanner in your fleet, which is great for if a large imaging enterprise such as ours at RadNet. And also, so any age scanner, any vendor, but also all the major OEMs are developing deep learning reconstruction or at different levels of fruition for FDA approval, but several of them already have FDA approval, and it does the same thing. And so you can see this is a standard image. When you accelerate, the image becomes blurry and at lower resolution. And then once you reprocess this with deep learning, you can see that the image quality is restored. In fact, perceived higher than even the standard of care. So here's the original, and this is what it looks like after deep learning. Again, original, and this is after deep learning. And why am I mentioning this? I'm mentioning this because this can actually be very useful to combine with quantitative volumetric imaging. So here we went 50% faster, and then we applied quantitative volumetric imaging. Here are the plaques. Sometimes these patients have a lot of, symptoms, and it's uncomfortable for the patients to be stuck in a scanner for long times. So this is a great thing to combine with quantitative volumetric imaging. And not only that, but this type of software increases lesion conspicuity. So you see these 2 white matter foci here on the standard of care. But when we accelerate and then apply deep learning, we can see that these 2 foci are more conspicuous, and that would be very helpful in patients with MS. And so we've looked at this through clinical validation trials, and it turns out that the quantitative volumetric biomarkers are absolutely consistent even after you accelerate and apply this AI software. So if the hippocampal volumes were 2 milliliters before, they'll be 2 milliliters after. So we're not losing any kind of information. There's really no downside. So again, standard, here's fast with quantitative volumetrics applied, and the same thing, half the time, but maintaining that quantitative accuracy. So in summary, quantitative volumetric analysis really adds value by decreasing the reader subjectivity and enhancing diagnostic accuracy, and also really aiding in longitudinal follow-up. Our referrers really love these tools. In fact, once they start using it, I've never had a referrer go back. So it's particularly relevant to MS imaging. And AI tools can be combined to decrease scan time and augment quality and really preserve that quantitative accuracy. Thank you so much.
Thank you, Dr. Bash, for this very nice presentation. It's always good to see someone who has been working with these quantitative tools for so long, and your experience is really very interesting. So next, we have Dr. Tanenbaum, who will discuss financial considerations. He will also review the key stakeholders and the future of this technology. Please, Lawrence.
Thank you very much to our sponsors. Thank you, Dr. Rovira. Dr. Rovira, it's pretty clear that age has its benefits in these circumstances. You know, when your hair gets gray, you're either going to be the moderator or put in the position of commenting on everybody else's presentation rather than doing the unique work. And I really enjoyed the presentations of Dr. Rocca and Dr. Bash, very informative. And you know, working directly for Dr. Bash at RadNet, I can tell you that I would echo all of her comments about the impact of artificial intelligence in terms of making quantitative neuroimaging a practical tool in the things that we can bring to bear in the clinical setting. So I've got less time. I've got about 10 minutes to just chat about things. And as is my typical bent, I decided to broaden the actual discussion because I figured that it would be well covered beforehand. And we'll talk a bit about how the full spectrum of quantitative neuroimaging fits into practice and what are the practical considerations, limitations, and challenges that we have to get this to be a real everyday exam. As you can see, there are a lot of companies playing in the AI space, and you may or may not know that quantitative imaging, while it started as a programmed application, this programmed tool has been substantially augmented and enhanced by the use of artificial intelligence. And there are a lot of companies in this space. Dr. Rovira pointed out that his startup is not on this slide, but I will promise you the next time I go out, Alex, it'll be right there in the middle so everyone can see it. Again, talking about actually following up on the discussion that Dr. Bash gave us in terms of AI uses in radiology, aside from making the acquisitions faster, it is essentially integral to the quality, robustness, and consistency of these tools. And frankly, this is because AI is really adept at doing things like segmentation, which is at the heart of what we do with volumetric imaging. You've already seen really nice examples of how these tools can segment lesions, can segment gray matter, can segment white matter. This can give us insight into a number of different disease states. You've already heard how these tools can be applied in MS, and that is the primary focus of this presentation. But frankly, when you think about these tools, they're applied every day in the evaluation of patients with cognitive impairment, early dementia, and are used in terms of taking the MR examination from ruling out a treatable cause, quote unquote, that might be neurosurgical, into identifying different subtypes of dementia and actually assessing risk in certain circumstances. It is also a valuable tool in looking at patients with epilepsy, perhaps looking for more subtle lesions or bilateral disease. And we're not going to talk about stroke, but frankly, when you think about quantitative neuroimaging, it is the perfusion application that really was the hallmark and primary, and still primary, use of quantitative imaging in day-to-day neuroradiology. You have heard in great detail the challenges of MS. You heard from both speakers that there is a challenge in inter-reader and inter-reader variability. Anecdotally, if you show a data set with 20 or 30 lesions in it to a large spectrum of readers, you will see an incredible variation in the number of lesions, in characterization of lesions. It is really tough to see if lesions are larger, lesions are smaller. It is even virtually impossible to do this as well as a computer can do. And that, again, is a constant theme of applying both computerized imaging and artificial intelligence into imaging. This is an example of a patient with epilepsy. You can see the volume loss on the right side, perhaps some surrounding gliosis, but is the left side abnormal? It's very difficult to tell those types of things without the use of a tool that is quantitative with comparison to normative databases and sensitive to abnormalities that may hide in the presence of symmetry. Other areas where quantitative neuroimaging is taking off is in areas like acute traumatic brain injury, giving the clinicians a real quantitative assessment as to the size of hemorrhages, the magnitude of shift, and the ventricular size in particular, before, after, and during interventions. These tools have also been used, quantitative tools, in terms of evaluating mild TBI and chronic TBI. We've seen the application of both volumetric imaging as well as things like quantitative imaging of the fractional anisotropy of the brain. An evaluation of neoplasms, taking us from the known limitations of 2D measurements, as we might do with RECIST type criteria, into full three-dimensional assessment. And you can actually lean on the quantitative, the segmentation qualities of artificial intelligence applications to take us from these 2D measurements into 3D measurements, and then also be able to segment different portions of the lesions, the enhancing portion, the surrounding T2 prolongation, the central portions that don't enhance, which may be necrosis, and use this to assist in the quantitative and more precise and accurate assessment of patients and lesions on an ongoing basis. I think one of the greatest potential applications or burgeoning applications of quantitative imaging is evaluating the ventricular system. I can't tell you how stressful it is as a neuroradiologist to assess whether the ventricles are a little larger or a little smaller, say after clamping of a catheter, and then walk into the neurosurgical meeting and watch 5 neurosurgeons second guess my assessment. Well, isn't the temporal horn a little bit bigger? Isn't there a little more shift? It is really nice to be able to rely upon a high quality, consistent, and essentially unbiased tool to make these assessments. And you can see how this might increase quality, but it's certainly going to increase consistency and reliability over time by removing subjectivity. So frankly, my goal was to talk about, and my assignment was to talk about some of the practical considerations that are keeping these tools from becoming everyday aspects of our armament. What are the practical considerations that stand in the way? Well, first of all, let's look at the stakeholders here. Aside from the patients who benefit from these technologies, we have the neurologists who will impact the patients with cognitive impairment. The focus of this presentation, diseases that are progressive and chronic, like multiple sclerosis, as well as difficult to detect and characterize, like epilepsy. We also have neurosurgeons, which will impact on some of these cases, certainly the epilepsy cases, the acute traumatic brain injury cases, but also cases where we're looking at surveillance of mass lesions, whether they're malignant or benign. We know meningiomas are very common. It can be very difficult to assess them, assess subtle growth, because 10% in any one plane is very difficult to perceive, but 10% in all 3 planes is really a big deal. And frankly, much better assessed with computerized technology than we do visually. And I've already alluded to the use in the ICU where patients are being evaluated generally around the incidence of neurosurgery. And then again, where radiologists start is really an interesting part of this pathway. While we are the ones who use the tools, because of a number of practical considerations, we need to be enabled and encouraged by the other constituents to put these tools to day-to-day work. So what are the barriers to keeping these tools from becoming standard of care, becoming expected and included on every examination when they make a contribution? Well, certainly would they need to be validated? And frankly, there's a reasonable amount of validation out there in the literature. They've certainly needed to be improved, and there's been an enormous amount of improvement over time with more reliable segmentation and augmented by tools like deep learning and machine learning. And I think we're at the point right now where we really have the best quality and the best consistency we've ever had. Most of our focus has been about the field of dreams model. For those of you who are not familiar with field of dreams, it's the radiologist has been told, build it and the clinicians will come. And, in other words, make the tool available and make the better mousetrap, and the world will be this path to your door. But frankly, that has not been as successful as we'd like. And there are a number of reasons for that. One is the clinical acceptance and awareness in the fields of the physicians who actually ultimately get the best benefit of these tools. And the neurologists need to be aware that these tools increase the value of the MR examination in things like multiple sclerosis and epilepsy. The neurosurgeons need to be aware that we have tools that will take the subjectivity out of assessment of ventricular size, that will actually translate what the images show into the guidelines that they use to determine outcome and treatment plans in acute traumatic brain injury. and the value of these tools in the longitudinal assessment of lesions that the oncologists and neurosurgeons see on a day-to-day basis. Ultimately, we need to convince these physicians of the value of these tools, so that because just building the tool doesn't seem to be enough, making the tool available doesn't seem to be enough to get these tools into day-to-day practice. So what are the limiting factors other than awareness in the clinical sphere? Well, the other limiting factor is, the payment models. How do we pay for these tools, right? And there are a number of different models out there. These tools all started with, use the report once, we'll charge you the charge, and you'll go ahead and figure out how you get paid. But it became very clear that with the array of reports, it's very difficult to prospectively figure out which one you need. So it became, over time, easier to get the vendors to go ahead and send you a variety of reports under a single charge so that you could go ahead and bring the best value to bear. It has taken a while to figure out which products are best, which ones that are most user-friendly, the most reliable, and the ones at hand. But fundamentally, the payment models can vary between per click, per number of reports, or essentially access to anything in the product portfolio that may be valuable in these circumstances. The models have shifted over time into circumstances where maybe you would subscribe for a year for either limited or unlimited access of a single tool or a variety of products. So we moved from the per click model into the model where essentially we just sign on with a vendor and make these tools available. In the per click model, you can certainly see the limiting factors in terms of making this real and everyday. In the subscription model, you start to become tempted to saying, are there insights that we can get from these tools on every case? The limiting factor here, however, is these tools come with a charge, and it is challenging for us to apply a tool on our own volition if it indeed increases the cost of the examination. And ultimately, we need help in these cases. First, it is better if we have the awareness of the clinicians who will then place the order, which would then justify the increased cost of the examination. This is difficult to do in at least the US economic environment, to add a cost without the urging and validation and request from the referring clinician. So it goes back to, the field of dreams model doesn't work. We need to get the order from the clinicians. And then ultimately, whenever we add cost to an examination, we'd like to find a way to get reimbursed for that cost so that we don't have to hand this cost over to the patients. Because really the two options are commercial payers, government-based payers, and out-of-pocket payment. And in our experience, there is some payment from commercial payers at this particular point in time. Some circumstances where the payer won't pay, we know this up front and we ask for out-of-pocket payment. There is no dedicated CPT code for volumetric imaging. There is widespread use of codes that are adopted from other applications, but these are not specifically legitimized, specifically endorsed by any of our societies or organizations. So ultimately, it isn't the ideal solution for how we go forward. So ultimately, we need for these tools to be requested. We need the radiologist to be aware of the benefits of these tools and put them to work. And Dr. Bash did a wonderful job describing the benefits in terms of increasing reliability, increasing workflow, and ultimately increasing the value of the examination without affecting any of our throughput. So we've talked about a lot of different things, and we'll certainly have a free-form discussion on all of these. I tried to give a broader discussion of the application of quantitative neuroimaging. I think all of the three speakers, certainly the other two speakers, did a wonderful job talking about the impact of these tools. And I tried to focus on how do we get to the acceptance in both the radiology community and even more importantly, in the clinical community. So the neurologist will ask for this examination, the neurosurgeons will expect this examination. And ultimately, I think as the utilization increases, becomes more common, and we need to focus on a way of getting more consistent payment for these examinations. So that's the end of my formal presentation. It was an honor to participate in this forum, and I look forward to some of the interaction that will follow. Thank you for your attention.
Thank you. Thank you very much, Lawrence, for this presentation. And I think that we have around 10 minutes for Q&A. But before that, I think it would be interesting to see the results of the poll that we made at the beginning of this webinar. We asked you 4 different questions. The first one is, do you routinely use a tool for automated segmentation? It seems that around 60% of the people say no, they don't use it routinely. Also for the question about the use of automated volumetrics, the similar results, almost 60% they don't use this kind of tools. The third question was, do you routinely use a tool for the volumetric assessment of lesions in MS patients? And also 60% say no. And finally, the last question is, are you or your colleagues exploring artificial intelligence-based applications for your practice, and similar results, but in the other way around, that 60% of the people is saying yes. So I think that the results are, I think that are quite good, in the sense that around 40% of the people are using some kind of tools, as the ones that you mentioned during your presentations. So good, interesting results of the poll. And then I have several questions from the audience, but before starting with these questions, I have a couple of questions. And the first one is, I would like to address the question to Dr. Rocca. And I'm aware that you've been using quantitative MRI-based measures for a long time, but particularly for research. But what do you think, what is the limitation that you see as a clinical neurologist in the implementation of these tools in clinical practice?
Okay, if we thank you for the question. If we think to implement these tools in clinical practice, I think it's important to differentiate the type of patients we want to study. So I think that there are many different issues when we want to implement these tools in clinical practice. The 2 main points is that we need to have a standardized acquisition protocol, as it has been already said by Dr. Bash. It's important that the patient is studied on the same scanner with the same sequence in order to be able to apply this method. And this is usually difficult to be obtained in clinical practice, at least here in Italy and in Europe. I don't know if in the USA is different. The other point is that it might be difficult to implement this tool in the diagnostic workup of patients with MS, because this might result in a even increase over diagnosis of MS, because we need only 2 lesions, and these tools will detect much more than the 2 lesions needed to demonstrate disease dissemination in space or time. So it would be extremely important to perform a careful integration of the results obtained with this tool, with the results obtained from clinical evaluation and from other laboratory testing, in order to try to control for this risk of overdiagnosis.
Thank you. Then I have one question from the audience that I think that should be addressed to Dr. Bash, and also fits quite well with the comments made by Dr. Rocca, in the sense that how do you report the volumes or the data coming from these automatic tools? How do you integrate these atrophy measures together with your visual assessment of the scans and your interpretation based on your experience and knowledge? So you combine both, or in other words, how do you manage the false negative or false positive results that you can get from these tools?
Okay, yeah, so that's a great practical question. I break my report into 2 sections. So one is just the MRI interpretation alone. So I first interpret the MRI, without looking at the quant tool. Then I have a second section of my report that has the quantitative volumetric imaging section. And in that, I put the plaque burden and then the change, and also where the plaques are primarily located. And so all of those components are added under a separate paragraph. As we were talking about, quantitative volumetric imaging is only as good as the accuracy of segmentation. But, I've been using this for about 15 years, and I see the different iterations as the versions improve over time. we are now at a place that the segmentation is actually very good. And, most of the segmentation can be done with machine learning, although there are some, in some areas that deep learning can be used as well to even improve the accuracy of the segmentation, particularly in the infratentorial region and juxtacortical regions, which are, because we use a FLAIR input, and sometimes lesions in these locations are better visualized on T2. But in general, the segmentation is very good at this stage, at least with the leading companies that are out there right now. But, as you've mentioned, it's not a perfect science. So sometimes there can be a false positive or false negative. If I think that there is something really relevant, I might add that into the quantitative, it's just sort of a sideline that there is. But in general, the plaque burden does tend to be accurate in terms of, because I can visually see the segmentation. And really, probably what's even more important than whether you have the perfect amount, a perfect volume every single time, is that you are accurately depicting change over a longitudinal study, because that's really what the neurologist needs to know. So let's say there was one false positive. If you reprocess using the same protocol and the same scanner, and it doesn't necessarily need to be the same scanner, but it should be the same protocol. Then if there is another false positive at the follow-up time, we're still getting the information that we need to know, because it's telling us overall if the lesion burden has increased.
Okay, thank you very much. I have another question, a very practical question that I will address to Dr. Tanenbaum. And the question is, how expensive are these tools? We know that in certain countries, it's not so easy to receive reimbursement for these assessments, and therefore it's really difficult to implement these tools. So, any comment on the cost of these additional tools? I think that also we need to consider, I would like to know your opinion, the cost of these tools in the context of the cost of MS in general, treatment in these patients. So what is your opinion on that?
Well, that's a whole bunch of questions. So let's not forget the last question. Don't let me leave without the last one, because I think the last one is really the more interesting one. These tools have a cost. The short answer to this question is too much, right? Everybody would agree to that. Everything costs too much. So let's just say that. What folks may not know is that all of these things tend to have different prices in different countries based on what the market can bear. An MR scanner in India costs a lot less than an MR scanner in the US, even though it's the same scanner. So I really can't comment. It is a relatively modest cost in the US. I would say maybe 10 or 15% added on to the cost of the MR examination if you were paying for it, say, out of pocket. But that will vary. And frankly, it's varied over time. They cost more earlier on. Now that they're being used more widely, the cost pressures and frankly, the economies of scale have made the prices go down. Certainly, one of the limiting factors before this becomes standard of care would be an even lower cost. But right now, I would say the costs are manageable. Now, the reason why I thought the last question was so valuable, and it really plays into your relative discussion versus the cost of the treating patients with MS, I commented already about against the cost of an individual examination, is about value, right? When we always talk about value, quality over benefit, cost over benefits. If the MR examination does not identify new lesions adequately, does not assess lesion burden, does not impact the treatment of a patient, the value of that examination is therefore zero. Okay, it has no value. If I miss lesions, if I can't do the critical assessment, if I can't assess the brain atrophy that may be progressing, it has zero value. So by adding this capability to the examination, augmenting and increasing the functional benefits of radiologist alone to radiologist and machine, the value goes up, in an infinite fashion. So frankly, the cost is modest, although variable. The impact is substantial, almost as much as to add value where there is none without the tool. And frankly, that's the way we look at it. So it would be wonderful to get reimbursement. This will be regional. It will be regional on a worldwide basis, as will the cost. But ultimately, I think patients are better served. The clinicians who treat them are better served. if we find a way to get over those limitations and integrate these tools when they're necessary in clinical practice.
Thank you. So I think that it's almost time to finish this webinar, but I think still we have some time for an additional question, and this is also a very practical one, and maybe I can ask this to Suzie. Is what about your experience in the reproducibility of this volumetric quantitative data when you use different scanners, or when you are using different tools? Because if you want to compare, for example, if you use tool A and compare to assessment made in tool B, are there different, there are any study that compare how robust are the different tools available? What is your experience on that?
Okay, so my experience of that is, first of all, the leading companies are working very hard to make sure that their algorithms are trained to be robust against different scanners of different models. So it's really not so much the scanner the patient goes on. We do try to direct our MS patients to our 3T scanner because we want to always make sure that we have that 3D flare input. It is very problematic if you're comparing a prior study that was done with a 2D flare input. It's slightly thicker slices possibly, and then they come for a follow-up with a 3D flare, because the 3D flare is going to detect more lesions. So that's going to impact the volume. The volume will be higher on the 3D. So, but as long as you have 3D flare inputs on both, or you're matching the same, then it really doesn't matter as much what scanner they go to, as long as that protocol remains consistent. And another component of that is that these versions get better over time. Every year or so, the leading companies will release new versions, and they do a better, even better job. Again, we're at a point now where the segmentation is really outstanding. So, but what you want to do is you don't want to just look back at the prior report and say, okay, my volume is 8 milliliters now, and the prior volume was 6 milliliters. I can see it on my PAC system from 2 years ago. What you always want to do is have the text push the prior study, the pertinent sequences. So they'll push the 3D flare and the 3D T1 through the portal, through the cloud portal to the company that they're using. And then that prior study gets incorporated and reprocessed. You push the prior first, then you push the current. And then that gets reprocessed and combined together in one current report. And the reason why that's essential is because now both the prior and the current are processed under the current version of the software, which is going to be a better version than the previous version. And so that's extremely important for the technologist to know that that's how we do it. It's much more accurate way of doing it.
Okay, so thank you very much. I think that also it's extremely important, as you already mentioned, to follow a high quality standardized MRI protocol. In that fact, I would like to recommend you the recent guidelines and recommendations published in Lancet Neurology by different groups in North America and in Europe. I think it's really important to follow these guidelines. And with that, I think that we can really improve the output provided by these tools. With that, I would like to thank today's faculty for sharing your experience on this topic, and Cortex.ai for sponsoring today's webinar, and also to our audience. Thank you also for attending today's webinar, and have a wonderful rest of your day. Thank you very much to all.
Thank you. Bye.